We are going to get started. Are you guys all able to hear me okay? Hopefully, yeah. Um, well, welcome to another CPC. We're happy to have you all here. I think we have a great case today that's going to be discussed with Dr. Nancy Sweitzer, who I think many of us know and love. The case is going to be a 69-year-old with a history of AFib, OSA, tachy-brady syndrome with a pacemaker, and heart failure with moderately reduced ejection fraction, and CAD, presenting with some progressive shortness of breath. Before we get into the case, we always like to get to know our expert. So first off, we're going to talk about Dr. Sweitzer. Many of you know her. She's a professor of medicine here. She's also the vice chair of our clinical research, vice chair of clinical research for the Department of Medicine. She's the director of clinical research for the Division of Cardiology, associate director of the Institute for Clinical and Translational Science, editor-in-chief of Circulation Heart Failure. She did her undergrad at Penn, MD, PhD in physiology at the University of Wisconsin-Madison, did her residency and fellowship at Brigham and Women's in Boston, and did her advanced fellowship in heart failure and cardiac transplant there as well. She has an even longer resume on her website. It's a very good read and very aspirational. I will now back to our one-liner. So we have a 69-year-old man, history of AFib, history of OSA, tachy-brady syndrome, had a pacemaker placed, heart failure with mid-range ejection fraction, and CAD. He's presenting with progressive shortness of breath. I'll give you an HPI and then we'll get your thoughts. So you are first seeing this patient in the ED. They were brought in after becoming short of breath in the GI suite after they were undergoing a scheduled EGD for ulcer surveillance. Procedure had to be aborted because they were hypoxic, requiring 6 liters nasal cannula. When you talk to him further, you find that over the last few weeks, he's had increasing shortness of breath and dyspnea on exertion. Now feeling short of breath, actually just walking a few steps. Previously, he could walk at least 150 feet. He's also experienced some weight gain, might be up about 15 pounds, thinks both belly and legs are swollen. And since you're a cardiologist, you also go through his cardiac history. He's new to Barnes, but you are able to get through some of his outside cardiology records. They're a little bit sparse, but you do learn that for his tachy-brady syndrome and or AFib with slow ventricular response, it's not entirely clear what the indication was, but he did have a pacemaker placed a year ago, and it was interrogated at his last office visit with his cardiologist a month ago, and had about 42% V pacing, seemed to be functioning appropriately. And then for this heart failure history, it's been going on for, this is 2022. So it's been going on for about 6 years. It was severe enough to prompt a right and left heart cath in 2017. Left heart cath did note 30% distal LAD disease, 80% PDA, and 80% posterior LV branches. He was medically managed only and has actually never had angina at any point. His right heart cath, you don't have the numbers, unfortunately, but you do read that qualitatively elevated left and right filling pressures, they do report an index of 2.3. And the last echo, you don't have the images, but you do have the read, which reported an EF of 45 to 50%, mild global hypokinesis, moderate RV enlargement and dysfunction, marked LAE, and moderate right apical enlargement as well. Historically, he's been on Entresto, Metope, empagliflozin, and Spiro, but the Entresto was stopped last visit, which again was just a month ago, for some hypotension. And then he's been on a pretty stable diuretic regimen without needing changes over the last year with Bumex and then PRN metolazone. So that was a lot. I'm going to give you a little bit more history and then we'll get your thoughts. So I had to like narrow the font size on this because he is taking like a full pharmacy of meds. For his medical history, we talked about all the cardiology stuff. I will say he also has sleep apnea and he is compliant with the CPAP. He has this recurrent history of gastric ulcers and gets scoped and surveilled that way. He has a history of a left hip arthroplasty with a chronic infection, and so he's on chronic suppressive antibiotics, does have type 2 diabetes and obesity. He's relatively bionic from a surgical history. He's got 4 replaced limbs or joints, I should say, but maybe limbs. He's had an appendectomy and a cholecystectomy. Family history is, ischemic heart disease, essentially. And then the meds I'm not going to read out loud, but we talked about the GDMT and the management of his CAD. He is on insulin for his diabetes. Socially, non-smoker, non-drinker, no drug use. He's a former dairy farmer. Worked for a couple of the years when he was starting to have heart failure symptoms, but has since had to stop working. And I lied, actually, I have the ROS as well, which I'm not going to read out loud. There's not a whole lot of new news on this, but I'll let you review that.
Okay.
So what do you think?
All right. So I prepared to talk about the case James sent me, which was a 69-year-old with OSA, diabetes, AFib, and heart failure, which was, I said, you know, hypertensive heart disease, thank you. But that's not a CPC. So this is more interesting. Obviously, this is chronic heart failure, not acute. His ejection fraction is moderately reduced, and we'll talk about that a little bit more when we see his echo, I expect. And he's got prominent conduction system abnormalities. He has a permanent pacemaker placed in, and he is pacing, which suggests to me that he doesn't just have tachy-brady syndrome, he has some degree of AV block or inability to conduct from the atria to the ventricle. So that rate, you know, arrhythmias in conjunction with a cardiomyopathy always give you a different differential, or at least change the order of things on the differential. One of the problems with the differential diagnosis in heart failure is everything's on it. Every heart disease known to man can cause heart failure. And so you start with a very, very large differential. But with this constellation of symptoms, you know, I would say the top three things, I have a few little notes because I don't want to miss anything, but inflammatory cardiomyopathies can cause this. They would definitely typically be more acute than have this sort of chronicity. But the multiple joint replacements and the arthritis history, you know, you got to think about autoimmune things and vasculitides and things like that that can sometimes cause cardiomyopathy. The infiltrative diseases, you know, would be very high on my differential in somebody who's got conduction system disease and a cardiomyopathy, because obviously infiltration of the myocardium and the conduction system can give you both those problems. Infiltrative cardiomyopathies tend to leave you with a very stiff heart, very prone to AFib. So his permanent AFib could well be in that under that diagnosis. And then genetic cardiomyopathies, I think, are also in there. Genetic cardiomyopathies can come in hypertrophic or dilated flavors. We're learning more and more all the time about genetic cardiomyopathies, many of which are monogenic diseases. You know, AFib and heart failure garden variety are polygenic diseases and not usually of interest in a CPC, but there are monogenic diseases that can definitely present this way. If he has a low EF, you'd think about Lamin cardiomyopathies in particular, non-compaction, ARVC, arrhythmogenic right ventricular cardiomyopathy, or now arrhythmogenic cardiomyopathy, because it's not always right ventricle. And then some rare causes of hypertrophic disease that are genetic, like Fabry's, Danon disease, things like that, that are very unusual, but somewhat treatable if detected early. Now, this man is 69, so my guess is this is on the late side to make the diagnosis, unfortunately. And then, of course, we have to think about amyloid cardiomyopathy, considered a rare disease until we had a treatment for it. It is clearly not a rare disease, and we have to look for it in anyone with increased wall thickness, especially who's male and in this demographic, or who's African-American. So I'll stop there.
Awesome. All right, so we'll give you a physical exam and some preliminary labs. So exam, he's actually hypertensive, heart rate's 94. He is on 6 liters when you see him in the ED, satting 94%. Generally speaking, looks short of breath, looks uncomfortable, and he's, you know, irregular on exam. The history physical exam does estimate a JVD of 9 centimeters, or JVP, I should say. He has distended abdomen that's non-tender, and he has 3+ lower extremity edema. I'm sure you've maybe seen an exam like this once or twice before. Moving into labs, I'm not going to read them out loud again, but not super exciting. And here's a CBC. So now that you have all of this rich information, where do you want to head first?
Well, so I'm a cardiologist. Do you have an ECG?
I do have an ECG.
Ooh, look at
This is
that.
the only one we have.
Wow. Okay, so he has serious conduction system disease, right? I mean, it's hard to find the normal beats in this. I'm looking at lead 2, and I'm not sure which are the sinus beats and which aren't. There's so many morphologies, right? So he's got a lot of ectopy from a lot of places, probably some atrial and some ventricular. Yeah, wow.
Is this steering you in any direction other than
Yeah, I mean,
sick
this
heart?
is an ECG of serious muscle disease, right? That's affecting conduction system, I would say.
Okay.
And so an echo, of course, our next.
You want an echo?
Oh,
you want a chest
chest
X-ray before your echo?
Sure. Gonna
What the
show
heck? Might as
failure,
well.
right? Yeah,
I'm not going to make you formally read the chest X-ray,
no,
but
it's fine. I
any
mean,
big picture thoughts?
he's got heart failure on his
Heart
chest
failure.
X-ray.
Heart failure. Heart failure. Chest X-ray. Yeah. Yeah.
Yeah,
I agree.
and a
Yeah.
device, a cardiac device.
Okay. Echo.
Now I want an echo.
Which fortunately this computer seems to have really wanted me to show you that echo video this whole time. So I'm gonna pull it up. I have some stills. I couldn't get the video to work, but I do have a video that I'll also show you. So actually let me show you the video first because that's probably more interesting.
So he has incredibly thick ventricular walls that are very hypocontractile. So this is a really important lesson, right? He's got a tiny little left ventricular cavity, and he's getting read as a mildly decreased EF of 45 to 50. But this is severely abnormal contractility of the heart. He has severe systolic dysfunction. And it's just that he has such a tiny cavity. It doesn't take much motion to reduce it by 45%. But this is severe systolic dysfunction and an incredibly hypertrophied heart.
Yeah, it's a pretty impressive image.
Valves look okay.
I don't think these are going to play. This is, oh, it decided to play, I guess.
Playing.
So that's the same image actually, but here's the windows are not great,
Yeah.
obviously.
Right.
And then this is obviously a still, but if you were curious for the strain.
So it's, I mean, it's interesting on the picture on the right there, the atria on your left is the right atrium, and it's bigger than the left atrium. So that's interesting. I mean, you'd think this guy's left atrium would be big.
Okay.
And then the strain image at the bottom there. So normal strain is about -20. And all of these are in the single digits. So that's very abnormal strain, which means there's very little myocardial motion. It's basically a motion detector. So like we said, his contractility is severely abnormal. That heart's hardly contracting.
And I think a question that I might have for you is, we look at those strains with patterns in mind, and we always talk about like apical sparing is one of the patterns that always comes up. Are there other patterns that you're thinking about or worried about?
Not really. I mean, this is a diffuse pattern, right? He's decreased everywhere. Obviously, in ischemic cardiomyopathy, you'll have abnormal strain in the infarcted area and relatively normal in other areas often. The cherry on top or apical sparing picture is that of amyloid heart disease. So this doesn't look like amyloid heart disease, but there aren't a lot of other strain patterns. We really look at global strain for the majority of cases.
Gotcha. Okay. What else are you thinking?
So we want advanced cardiac imaging.
Okay. Sounds good. Sounds good. Here, since you mentioned it.
Yes.
I'm just going to give you this because he was short of breath and you mentioned some myocarditis type stuff.
I mean, his heart failure has been going on for 5 years, so it's unlikely to be an acute infection. But I'd be interested in rheumatologic serologies, like ANAs and stuff like that.
Okay. Well,
more than
I can give you that while we're waiting for our advanced imaging.
The MRIs like 5 days from now.
Okay, so ANA is 1 to 160 and homogeneous. And ENA was not checked this admission, but it had been checked and was negative in the past.
Okay.
And then ESR and CRP were both not elevated.
CRP at 7 is elevated?
Or slightly elevated, excuse me.
Cardiologists care about that.
Okay.
Yeah, coronary disease risk
Yeah.
for sure at a CRP of 7 is elevated.
Okay.
But we know he has coronary disease.
Okay.
And I mean, I think that's worth commenting on, that this is not his coronary. He has coronary disease, but this is not what's going on. Coronary disease doesn't give you severe hypertrophy like this. It may make his incredibly thick myocardium even more ischemic, but typically in these hypertrophic cardiomyopathies, they don't have sufficient vascular hypertrophy to supply this kind of incredibly thick myocardium. So he's probably ischemic all the time, everywhere, you know, regardless of the degree of epicardial obstruction he has.
Okay. For advanced cardiac imaging, anything in particular you're looking for?
I mean, I think in 2025, typically an MRI is really the most useful test. If you're worried about coronary disease, CT angio, but we know his coronary anatomy, or at least some of his coronary anatomy. So I'd be really interested in cardiac MR.
Okay, so he goes for cardiac MRI and gets short of breath in the scanner.
Yeah, he can't lie flat. It's hard.
Can't lay flat for the cardiac MRI.
Yeah. So you gotta try and decrease his filling pressures if you can. If so you're thinking, what would I do if he can't lie flat in the MR scanner? I don't know. I'd treat him and get him so he could lie flat.
Sure.
Okay. But you know, with a heart like this, totally reasonable to biopsy him and look under the microscope. I would like genetic testing, as we talked about. There's these genetic causes of cardiac hypertrophy, that some of which are actually treatable. The problem with genetic testing, it's hard to do in the inpatient setting, although it's doable. It's very easy to mail to a patient's home and have them do it and send it in. And then you have to wait typically 3 weeks or so for the results. So you're not going to get any acute testing, genetic testing in this patient.
And when you mention biopsy,
yeah,
specifically, what are you looking for on a biopsy?
So in a heart this hypertrophied, we talked about infiltrative cardiomyopathy. So you can look for infiltrative cardiomyopathy findings. Diseases like Fabry's don't typically have a lot of findings. It's a metabolic disorder, but sometimes you'll get inclusion bodies and things like Pompe and Danon. They have very specific inclusion bodies because they're lysosomal disorders. And when the lysosomes aren't working, you accumulate all this stuff in the myocardium. So biopsy can be diagnostic in those cases.
Gotcha. Okay. I'm going to steer you a little bit because the ED did get a UA on this patient.
Okay.
Not entirely clear.
I saw urine studies.
Why, but
okay.
We did get it. Does have 1+ protein, and then that prompted, given his whole picture, he did get a 24-hour urine collection, and has 0.6 grams. So, you know, pretty mild to modest amount of.
I mean, he's
protein.
quite hypertensive. If this walked into your ER, you should diagnose him with hypertensive heart disease until, you know, it's clearly refractory, but hypertensive, long-term hypertension will give you these urine studies as well.
Sure. So as far as imaging, he doesn't get a cardiac MRI.
Okay.
He does get a targeted imaging study or something that you've been talking about.
So did he get a PYP scan for amyloid?
That's a great guess. And for that, we have Dr. Shadmani with our nuclear medicine department here to talk about the PYP scan. And I can run your studies, but if you want to, like.
Good afternoon, everyone. I am one of the nuclear medicine residents. Can I advance this slide? So for this patient, we have cardiac amyloidosis. Top right, you can see planar image that we usually start interpretation with planar images. You can see there is a tracer uptake in the cardiac region, apparently more prominent compared to the ribs. On top right image, we have SPECT images. It's a cine.
There we go. Okay.
Okay. And you can appreciate there is diffuse tracer uptake throughout the myocardium. And bottom images are SPECT, CT, and fuse images. You can appreciate there is a tracer uptake throughout the myocardium that's higher than the ribs. Next slide, please. So we use technetium-99 for this study. This is a bone-seeking agent that binds to the calcium content within the myocardium. Broadly speaking, cardiac amyloidosis can be divided into misfolded transthyretin, ATTR, and misfolded immunoglobulin related to light chain or AL. And ATTR can be further subdivided into genetic ATTR and wild type ATTR. That wild type, this is the problem with this case. It is the most common type. Older patients, usually male patients, older than 70. In terms of interpretation, a negative study can effectively exclude transthyretin cardiac amyloidosis, but does not exclude light chain amyloidosis because there might be the case present with AM amyloidosis, but the study is negative. So if cardiac amyloidosis is suspected despite a negative scan, assessment of monoclonal protein in serum and urine should be performed to assess for AL amyloidosis. And a clearly positive study, grade 2 and 3, can reflect either ATTR and AL amyloidosis, but has a positive predictive value for ATTR. And a mildly positive study can be either early stage ATTR and AL and should be further evaluated by assessment of monoclonal protein in serum and urine. Next slide, please. So this is how we interpret our study. First of all, we are dealing with old patients. Most of these patients have spinal spondylosis. As you can see, there is a lot of uptake within the vertebral body. That's why we compare myocardial uptake within the rib, because it's more reflective of bone marrow uptake. So starting from grade 1, as you can see, there is not uptake within the myocardium. It's completely clear compared to the blood pool. In grade 0, sorry. On grade 1, you can see there is a touch of tracer uptake compared to the blood pool, and you can appreciate a touch of tracer uptake within the myocardium compared to the central part of the heart, that's the blood pool uptake. In grade 2, the degree of myocardial uptake is equal to the ribs, and grade 3, as you can see, the degree of tracer uptake is higher than the ribs. And I think that's all.
So if we go back to their actual scan, where would you grade this?
If you look at the images, definitely the degree of uptake is higher than the ribs. You can see parts of the ribs, and this degree of uptake is apparently higher than the ribs. So it was read as grade 3 and obviously grade 3.
Okay, thank you so much.
And did he have light chains tested?
He does, yeah, I'll give you that.
It's really important not to miss multiple myeloma. You know, demographically, this guy is in the age range, and we would expect this to be wild type ATTR amyloid, but you got to rule out multiple myeloma. So, yeah.
Yeah, so big takeaway, SPEP had a possible abnormal restricted peak. Immunotyping was without a paraprotein. UPEP seems to have basically 24 hours worth of urine vanished.
Right.
So what are you going to do?
Yep.
Light chains, both elevated. The ratio was actually a little bit elevated, but nothing necessarily clinching diagnosis.
So for those of you interpreting light chain testing, there's a wonderful short piece in the journal Circulation Heart Failure, which I happen to edit, on interpretation of kappa lambda light chains in the setting of renal dysfunction, because they're differentially cleared. So kappa is cleared more by the kidneys, lambda less. And so in the setting of renal failure, kappa goes up disproportionately, and you get a tiny little increase in the ratio exactly like this. So this guy probably has some degree of renal dysfunction, and that ratio is completely consistent with that. But they have a nice little table, and it tells you what's normal for different GFRs in this paper. It's awesome. I pull it out all the time when I'm on the wards. So I think his light chains are not suspicious for multiple myeloma. Wild type ATTR amyloid is very interesting in that we know a lot more now about it than we did 20 years ago because we look for it now. There's a 9-to-1 male to female predilection. So men are far, far more likely to have this disease than women. Women do get it. You can't not look. But in an older man with very thick heart, it's always important to investigate for amyloid. I thought you were going to give me something. So I had a patient in Arizona who'd been ruled out for amyloid 3 times in Chicago where he was cared for, but nobody had done genetic testing, and he had Fabry's disease, which can look just like this and be an amyloid mimicker. So if you look for amyloid in a heart that looks like this and you don't find it, don't stop. You have to figure out what's wrong because something's really wrong. But yeah, this is a fairly classic presentation for amyloid, and he had it 5 years ago.
Yeah,
right?
I think that's the interesting part about this case is this
Right.
guy's been managed on GDMT. I
Yep.
mean, his cath was 5 years before you've
Right.
seen him, and
Yeah, his presentation with heart failure was in 2017, and he undoubtedly had amyloid then. And this is sort of a classic story for this, that the diagnosis isn't thought of, and so it isn't looked for, and then it's missed. These patients they have very restrictive physiology, so they don't tolerate vasodilators well. So his intolerance of Entresto was, a clue 5 years late. In the early stages of the disease, they will tolerate GDMT often, and they're often very hypertensive, and you want to treat their blood pressure, and then you give them something for their blood pressure, and they're hypotensive, and they're very hard to manage.
so last piece of the puzzle. You did mention a cardiac biopsy. Would you still like that?
More and more, I don't pursue biopsy when I have absolutely classic PYP scan findings and a good story. But, we're an academic center. It's never wrong to do a biopsy.
Okay, with that answer, I will give you the cardiac biopsy.
Yes.
Without the diagnosis, of course.
Right.
Do you have any thoughts on this? I think
Right.
we're pretty...
Amyloid heart disease is very distinctive on biopsy, especially if you use some special techniques. The pathologists here are not big Congo red fans. Oh, there's your...
this is crazy. I don't
Echo that
know. I'm not even
away.
touching anything.
So on H&E, they have this amorphous pale eosinophilic material, not always super obvious. Congo red is hard because you need the polarizing lenses, and pathologists don't like to do it. But there are other stains. I can't remember what the one that you likes to use, but there's multiple stains now that you can use to diagnosis. So the biopsy is very consistent, as is the clinical history and the echo and the nuclear imaging for cardiac amyloid, probably wild type ATTR amyloid.
All right, that sounds.
Is he African American?
I actually don't know,
Okay.
to be honest.
If he is, I would probably just genotype him for the mutation, not because it impacts his therapy, but because it impacts his family, right? He could pass that gene on to his family, and they can develop at a much earlier age. You see genetic amyloid, cardiac amyloid manifesting in people in their 30s and 40s. And so if he has children, brothers, sisters, worth testing them and he's positive. The prevalence of the most common mutation in the United States is 3 to 5% in the African American population. So a lot of people have this gene. They don't all get cardiac amyloid, but this guy, if he were genotype positive, has the disease, and you should cascade test his family.
Okay, there's our diagnosis. You absolutely nailed it. Fantastic. I'll give a little bit of background of his course. So he did get genetic testing and was negative. He was diuresed heavily. This is crazy. Okay, yeah, diuresed heavily. Initiated on further GDMT. Followed up with cardio-oncology outpatient. He was started on tafamidis, which, just as a sort of a teaching point, does prevent the misfolding of transthyretin, reducing further deposition. He was also started on patisiran. Patisiran. I was not familiar with this drug, but alters hepatic TTR synthesis to reduce availability for misfolding of the monomers. He progressed over the following 1.5 years. He eventually elected for inpatient hospice after a couple recurrent admissions towards the end of life. And that was sort of his course.
Yeah, so cardiac amyloid is a very exciting field right now. There are a lot of new therapeutic agents being studied, a lot of exciting new sort of avenues for treatment of these patients, including there are agents now that are basically depleter agents. They bind with the TTR monomers and basically kind of suck them out of the heart. And what we're seeing in people with these grade 3 PYP scans in depleter studies seem to have the TTR come out of their heart, their exercise capacity increases, their cardiac performance improves, and they're getting clinically better in early trials. We're in the phase 3 trials now, they're ongoing. If you have a patient with this disease, they can get into a depleter trial, and I would strongly encourage you to enroll a patient if you have such a patient. But even more exciting, at AHA in November, there was a gene therapy, a CRISPR gene therapy trial announced where you go in and you fix the genes in the genetic TTR patients and prevent the disease completely. And these patients typically, are sick enough that they are willing to take some risk with things like gene therapy. So I think we're going to have a lot of therapies, potentially even curative therapies for this disease within the next 5 to 10 years. It's really exciting. And all the companies are in the space and competing right now. So tafamidis is our first proven therapy. It slows the disease, but doesn't stop or reverse the disease. And patisiran similarly slows, but doesn't stop or reverse the disease. And we're really on the cusp of having therapies that stop and even reverse the disease. So very exciting time in amyloid.
Yeah, and it seems like, light chain tends to impact numerous different organs and has very varying presentation, whereas ATTR seems to be
Just
primarily cardiac or cardiac and liver. And so sometimes it seems like transplant can be an option if they're young and diagnosed early without comorbidities. I think even if this patient was diagnosed early enough, he had a lot of comorbidities.
Right. You see the genetic TTR patients getting transplants. They present in their 30s and they're otherwise healthy. The problem is that at least as of right now, the disease can come back in the transplanted heart. So I've seen that. I have several patients transplanted for genetic amyloid who now have amyloid in their transplanted organ. Fortunately, now we have some therapies for that, which is good, but the transplant kicks the can down the road, but is not curative in this disease. I was going to say, just interesting historical facts. So PYP scanning of the heart used to be used for diagnosis of myocardial infarction in the sort of pre-CAF days in the 1960s. Somebody would come in and we're pretty sure they'd had an MI. You'd send them to the nuclear lab for a PYP scan, and the infarcted myocardium would light up, and it would be a diagnostic test, and we used it a lot. And then it went away when we CAF people and diagnosed MI that way. But now it's come back because the heart is very PYP avid under these weird circumstances. But it's a bone scan that you use for cancer. It's the same sort of scan, but we're using it here to diagnose a particular cardiac disease. Yes. Thank you. Like sort of leash it out of the heart. That's what we want to do. Yeah.
Can you say a little more about prognosis? Say you have a 69-year-old man with stage 2 or 3 amyloid. Otherwise, healthy, get started in treatment. What difference in life expectancy? How do you issue life? And what would be the quality of the life that we're currently able to give with our new therapy?
Right. So excellent questions. So the question is, with our current therapy in a patient maybe not so advanced, what are the expectations in terms of life expectancy and mortality? So it is still a fatal disease. And because it was at the time of the tafamidis therapeutic development, it was considered a rare disease. So it went through the rare disease designation pathway at the FDA, which allows you to get drug registration and approval without mortality trials. So we don't actually know how much life is lengthened by tafamidis, but the curves for exercise capacity, quality of life, once you're diagnosed, it just goes like that. And on tafamidis, it goes like this. It's still going down, but at a much, significantly more shallow slope. So that's good. My patients tell me, they can't do more, but they're not getting bad so quickly. I think this will translate into a mortality benefit, but we actually don't have that data yet. We will have it pretty soon, I think. Before we had any treatment, from diagnosis to death was about a year to a year and a half for most of these patients. It was very rapidly fatal. It's a miserable death. They're dizzy and short of breath all the time, and you just can't diurese them. You can't get them to lie flat in an MR scanner. It's really, really hard to treat. And so we're all looking very much forward to the depleter trials to really start reversing the course of the disease. One other little pearl, which you didn't give me this, about cardiac amyloid is you get the highest NT-proBNP levels you'll ever see. They're typically in the 40, 50, 60,000s. In HFpEF trials, often the group with the highest NT-proBNPs doesn't respond to therapy, and I personally believe that's because you got a bunch of amyloids in that group that aren't going to respond to HFpEF therapy. So if you ever have a patient with a heart like this, a presentation and heart failure, and this amazingly high NT-proBNP, think about amyloid. It's another clue. The other thing is cardiac amyloid keeps company with renal dysfunction, with carpal tunnel syndrome. Somebody who's had especially bilateral carpal tunnel repair and presents like this probably has cardiac amyloid. And I've had, when we were giving talks on amyloid at Arizona, orthopedic surgeons started coming to cardiology. We're going rounds. And it was like, wow. But they were very interested in, can we help diagnose this earlier in the stage of disease? And so recognizing sort of the constellation is always important, right, for these complex diseases. Yeah.
Mention the difficulty of diuresis, practicability, heart failure. Does dialysis play an adjunct role in therapy for some patients for the removal of fluid?
So the question is there a role for dialysis in helping with the fluid? And unfortunately, the answer is most commonly no, because they're very stroke volume limited, right? You saw that tiny little cavity that with a very small stroke volume. And so typically these patients get hypotensive when you do anything, and dialysis makes them all hypotensive. They don't tolerate the fluid removal. And they typically die hypotensive deaths, actually. You end up having to stop all their therapies, and one day they just lose their blood pressure and they go. So actually death is relatively peaceful, hypotensive death, but the prodrome to death is really pretty miserable because they're super short of breath and they're dizzy. And that's just always a bad combination when you get that combination. Fluid overload and dizziness is bad. Other questions?
All right. Thank you so much.
Yeah, no problem. My pleasure.
Popping up. Yeah.